From the heartland of the United States and one of the leading children's medical centers in the world, welcome to the Children's Mercy Kansas City Pediatric Bioethics webinar series. We invite international leaders to discuss critical and controversial issues in bioethics. Now, from the Bioethics Conference Center on the Adele Hall campus, here's Dr. John Lantos.
Welcome, everybody, and Happy New Year. We're glad to be back here in 2017 with our bioethics webinar series. As always, we thank Children's Mercy Hospital and the Claire Giannini Trust for sponsoring these. We have a great schedule of webinars for this winter. Coming up this Friday, Rafi Cohen-Almagor is going to be talking about the new law in Belgium that permits euthanasia of children, and is going to discuss whether or not that's a good idea. On Monday, February 6th, Kelly Benham-French, a prize-winning journalist who just wrote a great book about her daughter who was born extremely prematurely, will be coming in to talk about that. And on February 21st, Lainey Friedman-Ross from University of Chicago will be here to talk about newborn screening for lysosomal storage diseases. So please join us for those as well. Let me remind people who are interested in our bioethics certificate program that the deadline for applications is February 1st. Many nurses are on today. We have a nurse leadership program as part of that bioethics certificate program. So if you're interested in doing bioethics in nursing, look at our website and apply to our nurse leadership program. It is a great pleasure today to have with us Ann Hamric from the University of Virginia School of Nursing.
Virginia Commonwealth University.
Virginia Commonwealth University. I pulled this off the web. That just goes to show you. Where she's been since 1999.
No.
No. Everything on the web is wrong.
I was at UVA.
Okay.
But I went to Virginia Commonwealth in 2011.
Got it. Okay.
And I retired from there.
She has been the senior editor of many books and is an internationally recognized expert on moral distress, and is going to talk to us today about moral distress in the pediatric intensive care unit. Let me explain something quickly, though, for those of you online. We usually let the speaker speak for 25 or 30 minutes, and then we take questions. Professor Hamric is going to break a couple of times in the middle, and we'll have a slide saying, we want your questions now. So if you have questions, type them in the little chat box in the lower right-hand corner of your screen. We will read them out and have discussion periodically as we go. We'll also be taking questions from our live audience here at the Bioethics Tower. Take it away, Professor Hamric. Thanks for coming.
Thank you so much, Dr. Lantos. It's a great honor and pleasure to be here and to be able to interact with you all on the issues of moral distress in pediatric intensive care. I am not an expert in pediatric intensive care by any means, and this is one of the reasons why I've designed this to be able to have comments and interaction from you as we go through the hour, so that you can be reflecting on what I'm saying in light of your experiences with pediatric intensive care. So I welcome your comments and your thoughts. There are many definitions of moral distress. I'm obviously going to share mine. It goes with the territory. One of the things that the original work on moral distress was done by a philosopher named Andrew Jameson, and he talked about moral distress as when you knew the right thing to do, but you couldn't do it. What a lot of people have focused on is the emotional distressing phenomenon of moral distress. They talk about the emotional distress. I have chosen to focus on the compromise to moral integrity, because I think that's actually the heart of this phenomenon. I think it's the reason it is of such concern in healthcare. And so when your integrity is seriously compromised, either because you cannot act in accordance with core values and obligations, or what you attempt to do fails. So many times people talk about that they tried to do something, but it was blocked or dismissed or not respected. And so even though they did take action, they did not achieve an outcome, and so they continued to feel distress. But notice some core elements here. It's about your integrity, and every time we do have a compromise to integrity, that is emotionally distressing. It is also integrity in terms of what our core beliefs are. So we have different core beliefs and values. Different professions have different obligations. But this notion of saying, when I can't act in accord with those, what kind of a person am I? That's at the heart of this phenomenon. I'm going to share a quote with you in a minute that I think is really spot on about this. There is a new wave afoot called the quadruple aim, which says that if we are going to achieve the triple aim of quality, satisfaction, and decreased cost, that we have to improve the work life of healthcare clinicians. I don't know if you all have heard about the quadruple aim, but it's a very interesting thing, and I think that it is also will raise attention to moral distress. The people who have written about the quadruple aim talk about burnout. And in my view, moral distress is a hidden and very pernicious element of burnout. That this notion of, it's not just I'm tired and I'm weary, I am beginning to doubt who I am as a person. I am beginning to say, I can't do this work, and think of myself as a good and caring healthcare professional. Key features of moral distress are obviously this notion of compromised moral agency, and I think that this is a very important feature when you hear people say, oh, I'm so morally distressed because I had this going on at work, I was trying to do this, I was trying to do that. Listen for whether there is compromised moral agency. I can be distressed for many reasons, and moral distress shares symptomatology, if you will, with burnout and with compassion fatigue and even with PTSD, but that doesn't mean it's the same thing. So look for this notion of I somehow violated a core obligation or value that I have. It's experienced by many healthcare professionals, not just nurses. I've said to some of you that the first study that I did of physicians, it was in 2007, and it was attending ICU physicians. And I was absolutely blown away that some of those attending doctors had higher moral distress scores than the nurses who worked with them. I did not expect that. Overall, they had lower moral distress, but I did not expect that some of the doctors would have higher moral distress than some of the nurses. And I'll show you some more recent data, and you'll see that is, it's experienced also by many other healthcare professionals, and we'll talk about that too. It is a subjective phenomenon, and this is confounding sometimes, this notion that some people will be morally distressed over a situation and the people they work with won't be. And it doesn't say that either one of you is right or wrong. It says, I have different senses of obligations. And this is what really trips up doctors and nurses sometimes, because doctors have a set of obligations that are very important, and so do nurses. And they're not identical. They're not the same obligations. And so we can get into disagreements. We can have different experiences of the same case. And then when you add chaplains and social workers and respiratory therapists on top of that, you see that you also have many other values and obligations at play. So it's a complicated phenomenon and a subjective one. Also, this notion of attempted actions being dismissed and not respected. One of the early critiques of Jamieton's definition was it made it sound like people didn't try to do anything. And sometimes providers who are experiencing moral distress don't try to do anything. Sometimes they feel like they can't act, but sometimes they do try to act. And so the issue is, when you try to act, nothing good happens. There is always a feeling of powerlessness. And this is part of what's been so interesting over the last 20 years in terms of all of us as healthcare professionals are feeling more powerless in many ways, either because of the dictates of insurance companies and insurers, the issues of profit and efficiency, issues of documentation demands. In all of those ways, there is this sense of powerlessness. So while in the early years of talking about moral distress just within nursing, there was this pervasive view that nurses experience moral distress because they were powerless in healthcare. Well, first of all, I don't think anybody's really powerless, but if you feel like you are, you act that way. So that's a pernicious little thing. Yes, that's another talk. But this notion of power differential, you always hear it in any of the dialogues from providers who are experiencing moral distress. The other thing is, I think moral distress can be very isolating. especially if you are experiencing moral distress, but you think the people around you aren't. Or you feel like it's really not okay to talk about that. Or you feel like when you do talk about it, somebody says, oh, you big wimp, just suck it up. You know, that notion of I can't really talk about this because it's just me. There is an inward turning sometimes that actually exacerbates the powerlessness. Secondly, always strong negative emotions, and sometimes that's a first sign that moral distress might be operating. Somebody said, oh, well, you can be morally distressed and not be upset. Well, no, I'm not sure about that. If you believe this definition that it's compromise in integrity, and you all have ever experienced a compromise to your integrity, that evokes strong feelings of anger, guilt, frustration. Right? You with me? Okay. Recurring and can leave residue. So we're going to talk a little bit about residue and regret and the reaction between those. So moral residue, defined by George Webster and Francois Baylis, is what we carry with us from the times in our lives when in the face of moral distress we allowed ourselves to be compromised. This is what remains after the situation is over. If we have compromised our core values, then we are left with this residue. And they talk about how these experiences are lasting and powerfully concentrated. And that's what actually got me interested in moral distress, was listening to nurses tell me these stories and how powerful they were and how detailed they were. And I would say, gosh, when did this happen to you? Thinking this had happened, in the last month. And they would say 10 years ago. And I thought, what is going on that this has stayed so powerful? And it's residue. In 2008, I was interviewed by Pauline Chen, a very interesting physician who writes a column for the New York Times. And she, from the interview with me and other people, she wrote a blog, a well blog or column on when doctors and nurses can't do the right thing. And there were over 300 responses within 3 weeks to this column. And one of the things that I've saved is this quote, because it's, to me, exactly what moral distress is. I quit nursing last month for exactly this reason. The stress on caring nurses and doctors is unbearable. Competent nurses feel frustrated at their own powerlessness, frightened of being sued, and heartbroken about what is being done to patients for all the wrong reasons. Furthermore, the healthcare crisis is so severe that all excellent practitioners worry constantly about mistakes that occur every day, simply because of the chaos in the system itself, not because anybody did anything incompetent. I came to nursing because I care so deeply about patients, but I left it because I want work that doesn't hurt me as a person. That last quote is the heart of the matter. Work that doesn't hurt me as a person. This is the experience of moral distress as compromised moral integrity, and that's why it's a negative phenomenon that we have to pay attention to. All right, I'm going to stop a moment, and I welcome comments or thoughts that you have. Questions, comments?
To remind people online, type them into that little chat box, and we will read them out. Jeremy, I thought you had a moment of moral distress there.
Conceptual distress. I'm just wondering if you can clarify a little bit what you mean by integrity, and if that is building in the concept of this deeply held convictions. Because I think a lot of us can say someone's morally compromised and mean by that their integrity is compromised and they don't necessarily realize it or care about it. But if integrity includes a strong emotional component as a matter of concept, like if that's just what it is to have integrity, is to have deeply felt convictions, such that if those convictions were, if something required you to give up on those, you would feel the pain of that because they're so deeply held. So I just wonder if you could say a little bit more about what you mean by moral integrity and the degree to which emotions are part and parcel of that.
Well, let me talk about it from the nursing perspective, because that's how I got socialized, so that's the easiest for me. So the provision of healthcare is a moral practice. We are not engaged in washing cars or fixing plumbing. So we are engaged with human beings, and that means what we do has a fundamentally moral component. And when we are socialized to become a healthcare professional, we are given a set of professional values as exemplified in our code of ethics. We also are given, we also come to a profession with personal values, with things that we've been taught made us a good person. We also are given, when we get into teams and work, we're given a set of obligations from our institution, from the people we work with, as things that we should hold as central.
Institutional integrity as well as.
Exactly, as central. So, and if any of you've ever quit a job because you thought you couldn't work in that place, then you know what I'm talking about. So, because organizations have values as well. Sometimes they live them out and sometimes they don't. But so all of that rolls in together to be a pretty complicated amalgam of the ground you stand on.
But technically, I could experience moral distress if, I could experience moral distress if any of those senses of integrity seem to be getting threatened or compromised in a given situation or relationship?
Yes.
Is that how you think of it, at least?
That is how I think of it to some extent. Now, I also think that in my own studies, there's a wide range of moral distress. There are people who have very minimal levels of moral distress, or what I would call small or moderate, and then there are people with great levels of moral distress. So it's not that it's an either or, you turn a switch and you're morally distressed. It can be a gradation, and how emotionally distressing that becomes to you is variable. The other thing I think is that one of the things we have learned in a moral distress consultation service that some of us developed at the University of Virginia is that people can confuse their personal values with their professional obligations. And sometimes people experience a distress that you can help really ameliorate by saying, let's separate your personal values from what is happening professionally. Can you see the difference? We're going to focus on our professional obligations here. So I don't know if I'm being helpful to you, but I think it is complicated, and that part of when you have someone say, I am morally distressed, is you want to say, what is the moral obligation getting compromised here? And also, are there other factors at play?
Other questions? Anybody online?
We do have some questions that are coming in from online, so I'll just take them in the order that they were given. And if some of these are things you're going to address later on, just feel free to say we'll get to that in a little bit. But the first question says, have you experienced pushback or defensiveness from management regarding recognizing moral distress in staff?
Yes.
Calling attention to this.
Yes.
I figured it. Do you want to elaborate any, or do you want me to move to the next one?
I think so those of you who have been involved in ethics consultation also experience this. I think there is this discouraging sense sometimes when you raise ethical issues, or you raise, and moral distress is an ethical issue in a profound way, that people say that's somehow a criticism of my leadership or my work or the quality of care that we're providing. And we have to really work to split those things out. I have told some of you about an experience I had once with a manager who said, my staff does not have moral distress. We are a really good unit. Well, they were a really good unit, and their staff was chewed up with moral distress. And one of the problems was this manager was so convicted that this was not an okay thing to acknowledge that none of them could really talk about it. So, yes.
In that situation, how did you deal with it?
Well, I unfortunately was not successful. I offered to meet with that manager. I offered to meet with any of the staff. I said, the staff had come to me, and I wanted to talk to her. I wanted to try to broker a conversation, but unfortunately, she was not interested in that.
I believe the same person has followed up that first question with a second that asks how you would recommend addressing that as a barrier to recognizing and supporting staff with moral distress. the resistance, the pushback, the defensiveness of management?
Well, I think that the more we can ingrain good quality ethics resources where people see ethics as a resource, not as the police coming in saying, oh, look, here's our list of all the things you're doing wrong. The notion of saying, how do we help one another be honest and open about the ethical dimensions of our practice is something that takes time and energy and effort. I think that if you have, for example, the example that I gave, I think that had I been in that institution longer, and I wasn't, that I would have continued to try to say, let's have a conversation. Let's look at these issues. The staff were going to keep on having moral distress. They were going to keep on contacting people, but they, I think over time, you have to build some different expectations that discussions of moral distress can actually be a positive resource to improve the ethical climate of a unit. And that takes a lot of conversation and a lot of kind of resetting of perspectives, if that makes sense. So I don't know a quick and dirty way to do that. I wish I did. Okay?
You have one more there?
Just my own follow-up, though, would be to think, I would think that there would be several different kinds of strategies here. One would be preventive in trying to keep moral distress from arising in the first place. And surely there must be some proactive strategies whereby we get more familiar with our colleagues. We know
We're going to talk about that.
Yeah, okay, great. And then there will obviously be ones where we can't necessarily prevent moral distress from arising, but we react. So.
Yeah, there are a lot of things we can do. So let's move on, and because I do want to have a good deal of time to talk about strategies, because I think there are a number. And I also will say, and you'll see this at the very end, dealing with moral distress in a complex system is a race to the persistent, not a race to the swift. So one of the things that you have to do, I mean, we started trying to address moral distress at the University of Virginia, and we worked at it for 10 years. And we now have a service that is embedded in the ethics consultation service. It's very effective. There is a lot of activity going on. There have been over 60 consults that we have data on. But I'll tell you what, if you had come to me in 3 years and said, are you making a difference? I would have said, absolutely not a hill of beans worth of difference. So it was just, okay, what's the next thing I could try? What's the next thing we can do? What is the next thing we need to work on? Because these are culture changes. They're not a change in one patient's management. And I think that makes it more complicated. Okay, you all have seen the crescendo effect. This is a model linking moral distress and moral residue so that you see that an individual patient case arises and creates a moral distress crescendo. Then something happens with that patient and the moral distress drops. However, if the moral distress has not been dealt with, residue remains. Then here comes another similar patient, and notice that the crescendo occurs again, but we're not at the baseline anymore. So over time, there are dual crescendos here. There's a crescendo of residue and a crescendo of distress. So you see this in, for example, a patient comes into the PICU and the experienced nurses go, oh no, we're not going through this again. Maybe this doesn't happen where you are. Okay, something is happening in their minds to evoke these previous cases. So Beth Epstein was a doctoral student of mine, and Beth was studying in the NICU. She was studying babies where the care had been removed and what happened then when the baby died. And so she was interviewing doctors and nurses about their experience of taking care of these children in that window between the removal of care and the death of the baby. So she did a phenomenologic study. She said, what was it like to take care of baby X? Well, they all told her about other babies. She didn't ask anything about other babies. She got story after story of the other babies, not the baby that she was asking about. So she kept bringing in these interview narratives, and we kept saying, what is going on here? And that was the crescendo effect. That's where we came to the crescendo effect. So this is one of my favorite quotes about the crescendo effect from a pharmacist. When I first started working on this, I didn't really think how widely this moral distress could be experienced, but I'm convinced it's experienced by many, probably all healthcare professionals, if they stay in practice more than about 10 or 15 minutes. Okay, so I left a major medical center after 27 years. I worked with a transplant surgeon whose only desire was to perform the surgery. The surgeon would promise patients I would provide them with their immunosuppressants, which cost about $1,000 a month, even with Medicare paying 80%. The result, after transplant, some patients couldn't afford the drugs and would start showing symptoms of rejection. Some patients told me it was my fault they lost their kidneys. After telling the physician I thought it was unethical for him to promise prescription assistance to these desperate patients, I was told by my boss that I was being written up and he wanted me to sign it. Not only did I not sign it, I left that day. At least I can sleep at night. You see the crescendo effect there? There's an erosion that happens over time. You want to talk about the notion of integrity. That's part of what he's saying. I had to get out after 27 years to be able to feel okay about myself as a professional. All right, in 2012, we did an instrument development study. Always, they're such fun. These were the top findings that we saw. This was physicians and nurses. And one of the things that's interesting in studies with physicians and nurses is it's frequent that the top items are the same, even though the doctors tend to think they don't happen as often as the nurses think they happen, which probably says a lot about nursing being setting bound. So following families' wishes to continue life support, even though it's not in the patient's best interest. Initiating extensive life-saving actions that, in my view, only prolong death. Continuing ventilators. This, again, was an ICU study for hopelessly ill people. But now watch this. No one will make a decision to withdraw the support. Giving false hope to patients and families. And false hope is a tricky wicket. That'd be another talk. Mm-hmm. Watching quality suffer due to poor communication. So poor team communication shows up a lot as a top item. And then also lack of provider continuity, the continuing changes in who is taking care of patients so that plans don't get put together and communicated in a straightforward way. Now, this is a more recent study, and this was a study of other healthcare professionals. This was a pretty big study. I think we had about 500 to 700 people in this study. And one of the things that was very interesting to me is that the direct care healthcare professionals, such as respiratory therapists, physical therapists, social workers, they had as high levels of moral distress aggregate as nurses did. The other healthcare providers ranked 3 items higher than physicians. And in another study that's been done more recently, a qualitative study, they saw the same thing, that the other healthcare providers had some different top items. And these were the 3 items that were ranked higher. Poor team communication was ranked number 1 by this group, and that makes sense because they are interacting with lots of different teams. So they're pretty vulnerable to the quality of the team communication. Working with incompetent providers, they interface with a lot of providers, and so they marked that higher. And in my Canadian colleagues' work, working with incompetent providers ranks near the top in all their studies. And then also caring for hopelessly ill patients when no one will make a decision. Now, the other thing that was so interesting to us in this study was that providers with pain management and end-of-life training actually had higher moral distress. And my thought about that is when you go into pain management training or end-of-life training, you get a new set of expectations, right? You learn, here is the way we should be caring for patients at the end of life. Here is the way we should be managing pain. And then you go back into your setting, and if the people that you go back to go, well, how was the meeting? Did you have a good time? Oh, they taught you what? Well, we're not going to do that here. You then have a level of disconnect, right, between what you now understand you ought to be doing and what you are doing. So that just giving people training, if you're not paying attention to the climate and environment in which care is provided, can actually increase moral distress. Does that make sense? All right. So I want to break here because all of you were also asked to read the case study on moral distress that looks at the root causes in that particular complicated case. It was a NICU case, but I also welcome your thoughts on additional root causes that you see in pediatric practice. So, thoughts, comments?
One thought about the case, as I recall it, and the top 3 causes of moral distress is they all seem to have a lot of overlap. It's all about when do we say enough is enough, and how do we decide when it's time to stop. And that seems to be...
And whose view counts.
And whose view counts, and who has the power to say,
right, now
we're going to stop. So somebody should make a decision.
Yeah.
But it's not clear necessarily who should make that decision.
And sometimes I think that families are just handed this very complicated thing and say, you decide, and I think that's very difficult in some situations. In many of the times I've seen the families had a poor understanding. They were grieving this hoped for baby and all the challenges, and they were in a terrible position to try to be decision makers. Yet the team said, well, it's your decision. What do we do? And I think that's challenging all by itself.
But it seems like the solutions would be very different for that situation versus, say, an incompetent provider
Yes.
or poor team communication.
Yes.
Or you could imagine solutions, institutional ethics or organizational solutions.
Yeah.
That may be difficult and may not work, but
Yeah.
with the futility cases, it seems like the oppressor, if you will, is often from the outside, that it's not that nobody will make a decision, but that we're required by law to behave in a certain way. So nobody can make a decision.
Yeah. Well, or that we feel like we're powerless.
Okay. You think we're not?
I don't know. I mean, I have seen situations where the staff was not as powerless as they thought they were.
Okay.
There are other situations where they are. So it's complicated.
Yeah.
And one discussion that comes up a lot, it seems like sometimes when nursing groups are talking about, it is that there's these options when you were talking about the families to make the decision, but there are so many options that they're giving, and sometimes those aren't even realistic options. But it's just that possibly we could do this, possibly we could do that, and then it complicates that decision making even more, creating the feeling within those caregivers, why are we doing this?
Yes. Yes. That's great. These are great comments, both of them. Anybody in cyberspace saying anything?
I can't tell that any of
these are directly related to this question, although there is a question that maybe I can kind of twist to make it just a little bit, which is, it's not exactly the root cause, but someone notes the issue of contagious moral distress that they've noticed in the whole unit beginning to struggle together regarding challenging cases. And you have potential for hearsay and judgment and potentially causing more harm when it's not addressed effectively by leadership. So the proximate cause may be the sense that all of one's colleagues are experiencing this, and that kind of catches with you, but that's not the root cause. There's something else going on that's getting it to that point, but they did want you to address this issue of contagion and what you might have to say about it and what you might suggest to do about it, I guess.
Well, I think that's a very great comment, because I think it's a real phenomenon. And sometimes when we would go in to consult on a moral distress case, there would be tons of people there, not all of whom were taking care of that child, but they had taken care of similar children. They were involved from a distance. So different than I am in the middle of taking care of this child, but seeing that there was moral distress by proxy, if you will. So I think that's a very real phenomenon, and particularly where it's not being openly discussed and addressed. If these are lounge discussions, on breaks, they can assume a form where no one is really shining a light on what's going on here to try to separate that out or deconstruct it, if you will, in a way that will be positive.
It seems like the moral residue can be kind of transferred to others, and then it makes it, like you said, the crescendo effect kind of picks up that way as well. So it's not even necessarily my own moral residue over time. It can be distributed between colleagues and within units and such. So.
Yeah.
We've also found on the contagion thing that sometimes it is based on poor communication, so that some people will say, nobody's talked to this family about the possibility of withdrawing life support, and that's a terrible thing, and that's causing me moral distress. And then when we bring people together for comprehensive care rounds, we call them, the attendings will say, I've talked to the family 5 times, and people go like, oh, well, that's a different problem than we
That's
thought
absolutely
nobody was
right.
talking.
And so you'll see one of the first things in starting with moral distress is get the full story, get the whole story, because we all are getting a piece, and especially at the pace that patients cycle through our inpatient facilities. Now you all keep patients longer. It's pretty interesting, pretty cool. But in a lot of acute care settings, the turnover is rapid, and so everybody's getting a little slice of what's going on. So coming together and hearing the whole story can absolutely take away the moral distress of providers sometimes.
Or at least lessen it. Yeah.
Yeah.
You have a question, Laura? No.
Okay, I'm gonna keep going quickly. So here are 3 responses that we see in the literature. One is burnout and leaving a position, leaving the profession. One is conscientious objection. Anywhere from I'm just saying, here's my opinion about this, or I don't feel good about what we're doing, to refusing to follow orders. And the third is just I bracket off the moral dimension of my practice. I get desensitized. I just complete my do list, and the rest of it is not my problem. All right, so here's a little thoughts on each of these. So leaving due to moral distress. So this is from the 2015 study, and when we first studied nurses and physicians in 2007, so that's about 10 years, because we actually did the study in 2005. So it's about 10-year difference. The numbers of nurses considering leaving was 20%, so that hasn't changed that much. The number of physicians was 3%. Considering leaving compared to 20%. That's a big change. The other healthcare providers are actually lower, but look at the people who considered leaving in the past. That's a pretty significant number in each category, if you ask me, of people who actually considered leaving in the past or left a position in the past. Now, and obviously we're not capturing leaving the profession, because these are people who are all still working. Anita Catlin, who some of you may know, surveyed 66 NICU and PICU nurses in 2008 about this issue of conscientious objection. And here's what's significant to me. Over half of them wanted to object but didn't do anything. That's huge. Now, I would like to think if we did the study now, that would be lower. But if you notice, if they did object, look what happens in decreasing order. Very few people documented that. Very few people called an ethics committee. And for those of you who read the case study article, you know that I reference Bob Trug's commentary on a recent critical care thing where only 1% or 2% of people had called an ethics committee. And that was last year, 2016. So I don't think we're making as much progress in seeing the use of ethics resources as we need to be. But the other thing that worries me about, well, there are a lot of things that worry me about this study, but one of the things that worries me is this covert refusal to follow orders, because that doesn't change anything. It really doesn't change anything. There's a very interesting article that was done decades ago called Responsible Subversion, and that's what this is. But the result of responsible subversion is maybe it makes you feel a little better, or you refuse to take the assignment or whatever, but it doesn't change the environment in which the moral distress is coming up. You know, it isn't changing anything. So over time, that can just increase the crescendo effect. Does that make sense? This issue of withdrawal, this was a new nurse who said, I had an experienced coworker say to me, that's why I don't choose babies that are sick for a long time like that, so I don't have to go through that. You see that bracketing, that desensitization? Some nurses, and this is the new nurse talking, some nurses just don't have the feelings anymore, the same type of compassion, because it's hard work and you get to the point where I guess you have to let go of some of those feelings. Now look what has been taught to her. Look what she has learned. That's a little worrisome. I think our patient, you know, at least in adult patients, but also children and families, don't want people who have let go of the compassion because it's just too hard. But I think that's a great quote for exemplifying this routinization problem. Okay, now I said other responses, but we're going to keep moving. What can we do about this? Okay, initial steps. I already talked about getting the whole story. Second of all, there is no excuse for speaking up. There's no substitute for initially speaking up and trying to talk about this and encouraging a dialogue. That's why, you know, if you spend more time with me, you'll keep hearing, I tried to have a conversation. I tried to have a conversation. We have to start by having some sort of dialogue about this. What many people say to me is, I couldn't do that on my unit. Well, that's the first problem then. What's going on your unit that you can't speak up? Why is that risky? That has to get dealt with before anything else can happen, in my opinion. Focusing on ethical dimensions of care. What ought we to do? What is the moral issue here? What obligation is primary? What are the goals of care? Have they changed? Do they need to change? If you read the case study, you say that you see that I said that we spend more time talking about lab values and physiologic parameters than we do talking about these things. And that we have to create some space. I've also done a thing on ethics resources and creating moral spaces within healthcare institutions, and that's the way I see an ethics resource. Essentially, it's a moral space for dialogue and deliberation within a complex organization that focuses on the ethical dimensions of care. And how do we bring that into day-to-day care provision? So these are questions that we are considering along with the lab values. I'm not opposed to lab values, but I just don't think that that's the whole story. And I also think that one of the problems with that kind of focus is that the nephrologists say one thing, the pulmonologists say another thing, the cardiologists say another thing, and the families hear all of this mixed information, and they conclude things that we don't really intend because they're trying to piece together this different kind of information they're getting. Instead of saying, let's focus on what the goals of care need to be. Here is what has happened with your infant. Here is what's not going to change. We have to be looking at what our goals are. Easier said than done. I appreciate that. Recognizing and naming moral distress. One of the big things that's happened in the 20 years I've been trying to hang on to the tail of this tiger is that people are now talking about moral distress. They're using the language. Sometimes they're using it wrongly. Sometimes they're just talking about emotional distress, but a lot of times they're not. And so in the old days, nurses would say to me a lot, I thought it was me. I thought there was something wrong with me. I didn't know this had a name. I didn't know this was a real live phenomenon. And now I think, particularly in medical centers and centers such as the one here at Children's Mercy, you're having a lot of dialogue and discussion about moral distress. And so that's a very helpful thing, because I think we can help each other, and we can move forward together when we give this thing a name and know what it is. Recognize that strong emotional reactions and recognize that repeated things show crescendo effect and structural problems. Now, here's the reason why I think it's so difficult to deal with moral distress. Really addressing moral residue crescendos means we have to move beyond the case. Our ethics consultation, I've done ethics consultation since the 1970s. I'm very old. And I learned to do good ethics consults that was very case-based. And how do we help a team or a provider make good decisions in a situation of one case? That is not the issue with moral distress. So if you go in and most of the time, because if these are underlying structural problems, if these are team communication issues, if the root causes are grounded in things that mean that every patient who cycles through the same thing happens, then case-based intervention doesn't have it can't achieve the outcome you want. So we have to move beyond the case to unit team cultures and organizations and systems. And so here are some ideas, and these are all referenced at the end of the slide set. So all of you, I think, can get these references. But we now have at least four evidence-based interventions, which is exciting. The unit-based ethics conversations that Lucia Woschel and her colleagues have done at Indiana Health. CERN was a grant-funded program, which unfortunately is not continued post-grant, that was done up in Boston at Brigham and Women's and Mass General for education for nurses. And it was a whole year-long program, very involved, very interesting. It made a significant difference in moral distress levels of the participants. The Moral Distress Consultation Service has just been published in the HEC Forum, and it is a more interprofessional focus, not a nursing focus. And then the Ethics Champions program, which 3 hospitals, including yours, are involved in, is a very exciting thing that I just learned about at the American Society of Bioethics and Humanities last October, and I jumped up and grabbed all 3 of those people and said, publish this, publish this, publish this, because it's really important. It's a great program, and the fact that it's multi-site and you're doing some data gathering, very exciting. So if we say moving beyond the case with teams, first of all, here are some thoughts about teams. You have to create a space somehow to talk about the ethical dimensions of care. And in my experience with moral distress, it's much more effective if it's interprofessional. I think it's important for nursing to understand and support each other, but I think that most situations of moral distress are interprofessional in their root causes, and they have to be interprofessional in their solutions. Nurturing the expectation of collaboration among teams. When I first started as an advanced practice nurse, I used to say that my job was to teach other team members how to collaborate. I think we know a lot more about collaboration now, and we know a lot more about the effects of collaboration in terms of patient outcomes. Pretty significant stuff. So nurturing this expectation that we come together to solve problems together and that we are open to diverse perspectives. But then this is another big thing. We have to speak with one voice to the patient and family. I have had too many situations where the family member hears, well, the kidneys are working better today. Well, the kidneys are working better today, but the lungs are shot. But they don't get that. They just get, or the blood gases are better today. And so what does a family think? They think that that baby is better because the blood gases are better. The BUN is better. No, the bigger picture is still dire. The bigger picture is still not good. So how we come together to speak with one voice to help patients and families. And you know, the data is that patients and families hear 30% of what's said. So if you say it once, there's a 1 in 3 chance they got it, or they got a third of it. So we have to be doing these things over, and how do we clarify goals with our patients and families? Patterns and processes that support moral integrity. Now this is more on that institutional level, okay? If we think about a system level, clear administrative support for any healthcare professional to speak up with a question or concern. I said, I would like, before I shuffle off this mortal coil, to hear about a place where you get in trouble if you don't speak up. Wouldn't that be cool? You know, if we have a culture where everyone speaks up and raises their concerns, and we work together to address the integrity and protect the integrity of each person. Early, frequent, consistent communications. There are lots of strategies for this. Family meetings, there are team, different places have developed a way for a team to appoint one person that's the spokesperson that interacts with families. I mean, you can find many different strategies, but the heart of the matter is early, frequent, and consistent communication. The other thing is when challenging cases occur that you go back and talk about them, and you don't talk about them to just debrief in the sense of, this was awful. You do it with an idea of what could we have done differently? What did we miss in an early signs that we were going to have difficulties with moral distress? What did we miss? How could we do differently the next time? If we get another baby like this in 2 weeks, what will we change? That notion of saying what will we change is what is powerful in a debrief. And then using ethics resources and seeing that as expected rather than exceptional. This is a very big issue for me in terms of if we create a moral space. So one of the things that was difficult for me with that nurse manager who said, I have a good unit, she never wanted to call an ethics resource. She didn't think it was needed. It had the view in that institution of being exceptional. You only call ethics when things are really bad. You don't call ethics when you just have something that is upsetting somebody. If we move to a climate where you call ethics when you have issues, you don't wait for them to get bad. I think that's where we have to move. And I think it's actually much more time effective. Okay, so here is a set of criteria for, well, you can think of these as a set of criteria, okay? So one thing would be, how would you diagnose your central team, because many units have more than one team, or how would you diagnose your institution in terms of these criteria? If you say, we are doing a good job with this, we call ethics when we have an issue, we support each other in raising questions and concerns, then you're far along to trying to have an institutional response to moral distress. On the other hand, maybe it's a little bit different for you. All right, so here, okay, this is my shtick about institutional ethics resources and moral spaces. I think there are 4 key categories for any ethics resource to be effective. And I also think we need to think about ethics resources as broader than just an ethics committee. You can have a shift huddle that's an ethics resource. You can have a chaplain who's a powerful ethics resource. The issue is these resources have to be, number 1, available, number 2, known about, and this is not easy. In one study, the nursing staff, even though they had worked for, on average, 7 years at the institution, 40% of them didn't even know they had an ethics committee. Well, if you don't know you have one, you're not going to call them. The notion of when you do call them, they have to be knowledgeable. They have to help you. That's another worrisome thing. And this article on moral spaces gives all this data, so I won't take time with it if you're interested. But the number of nurses who say, well, we called ethics, but they weren't helpful, so we're not calling them again. And they have to be sanctioned. If you get in trouble for calling a resource, you are much less likely to call that resource a second time, not to mention a third time. So the notion that we expect and sanction the use of resources, just like if you have a child with a kidney problem, you call a nephrologist. You don't have a big discussion about whether that means you're a bad provider. You just call the nephrologist. So the notion that if we have an ethical problem, we call the ethics resources because we need help with figuring out how to manage that. It ought to have that same gestalt, but it doesn't always in institutions. Okay, are there any problems with this? About 1,000, and I just ran out of room on the slide. This notion of time, I think is a huge bugaboo, but frankly, the timely use of ethics resources saves time. It doesn't create time. I can't tell you how many times I've been in consults where I thought if you had only called us 3 weeks earlier, we could have done so much so quick, and this is a giant mess. So this notion of time, we have to be careful about it because we're time constrained, all of us. But sometimes you save time by using ethics rather than create time. Lack of continuity is something I think every team has to look at, how we're doing that, to provide some sort of way that we communicate clearly with each other and build a sense of team collaboration, even with lack of provider continuity. And that's a tough thing to do. Issues of hierarchies, moral superiority. I don't think any of us stand on the moral high ground. I think we all have to struggle with different cases and different situations to see how can we make the best decisions here. And so sometimes moral superiority can be a real barrier to creating an ethical culture. Multiplicity of providers and teams and others. And then a final set of questions, oh my goodness, and then I'm stopping. Where are you in terms of the crescendo effect? So these are another kind of set of diagnostic questions. Are you giving explicit attention to moral distress? Can you discuss moral distress without fear of reprisal? I am stunned at recent qualitative literature on nurses at how many people fear reprisal to raise ethical dimensions of practice. It is stunning, it is scary. It is something we have got to work on. And how could you, to strengthen the ethical culture that exists in your settings? Here are references, more than one, and I think you can get these slides in some way. John,
we can post them on our website. Yep, we'll post the slides and the references.
Okay, so we have...
And we have time, 5 minutes for a few questions or comments. I have one if you don't have some online.
Got too many, that's the problem.
Oh, okay. Well, let's do
But
this.
let me, I can combine 3 or 4 of them by just saying some people have come in with some ideas of root causes and things, and maybe I'll just throw them out, and if you want to pick up on 1 or 2 of them. So people have noted the disproportionate influence of power players like surgeons who maybe had especially time crunch schedules to get a whole team together and address some of the root problems. The impact of deep cultural or religious differences, and a sense in which moral integrity might differ depending on one's tradition you're embedded in. Lack of family involvement in many cases, or parental absence in pediatric cases, as well as a tightening fiscal environment in which resources can be limited artificially or naturally.
Let's take those for starters. And then we'll see if we have time for some more. You want to say something about some of those issues?
John has this vaunted notion that I have answers to all these questions. I just spend a lot of time looking at the questions. Okay, so the notion of the first one, the disproportionate power of certain providers to limit dialogue. I think that's an administrative issue, and so you have to have an administration that understands and respects that moral distress is an important issue and that we have to have providers who feel that they can operate with integrity, and they will have to deal with any powerful individual who is constraining team efforts. So I think that sometimes when you see that, it's very useful to get administration involved so that administration sees this has been one of the tipping points for the Moral Distress Consult Service. Was we began to send the reports, the administrators would see the reports and they would see, wow, this is what's happening on the ground. And it's not something that we can support. We have to take some action. So I think that's one thing. This issue of tightening resources is, who knows what's going to happen in the next year to the whole issue of how we structure and pay for health care. And I don't have any easy answers for that, except that if we are talking and working together, we can come up with solutions. I am very impressed at every moral distress consult I've ever done that when we talk about strategies, what could you do about this? It is invariably the staff have lots of strategies. They have lots of ideas, but they play yes, but. You know what I'm talking? Yes, but we couldn't do that because of this. But I go, take away the but and just tell me the ideas. And frequently from within those, we prioritize 2 or 3 actions that can be taken right away. And that is a powerful antidote to powerlessness. So this notion of we don't have the resources, well, what could you do about that? Well, we used to do this one thing, but we don't do it anymore. Well, could we do it again? You have to move past the but it won't work to explore different ideas. And even if you come out with 1 or 2 things, it makes people feel like they have more agency. You know, they don't feel as compromised because it's like something could happen. Okay.
I'm afraid that's going to have to be the last question for this webinar. I wish we could go on for another hour. For those of you in Kansas City, Professor Hamric's doing an ethics brown bag lunch at noon right here at Children's Mercy Hospital. So if you want to come to that, come on down and you can ask some more questions and discuss these issues in a little more depth. If you're not in Kansas City and you want to talk more about bioethics, apply for our bioethics certificate program. The deadline is February 1st. We have a nurse leadership program that's a wonderful program funded by the Claire Giannini Trust that pays half your tuition in our certificate program and gives you resources when you go back home for the next 3 years. So stay tuned, join us for the upcoming webinars, and thank you so much for a great discussion.